In this session about liver cancer. This is the Liver Cancer Summit. It's my pleasure to introduce my co-moderators from right to left, Dr. Philippe Pereira, President of CERSI, Dr. Muhammad Mustafa, Professor of Intervention Radiology in Cairo University, and Professor Osama Hetta, Professor of Intervention Radiology in Ain Shams University, and myself, Dr. Ahmed Kamel. Our first speaker today would be actually myself, and I will be talking about radiation segmentectomy for HCC, technique and outcomes. Okay, sure. Thank you so much. We're going to start my presentation now about radiation segmentectomy for HCC. These are my disclosures. And as a background, Y90 can be delivered in different fashions. You can do it bilobar, you can do it in one lobe only, you can do it in a segment, and you can deliver it subsegmental, as you can see in this diagram. The idea about radiation segmentectomy is not new. It actually started by this publication in 2011 by Riaz, one of the Northwestern group, which basically we go with our microcatheter. This is an example of a tumor here in the left lobe of the liver. We go with our microcatheter very close to the tumor, and then we inject a very high dose of Y90 to the extent that it will actually kill the tumor as well as the whole segment or subsegment in which that tumor is present. This is how it looks afterwards. You can see this triangle here has a radiation induced effects by the high dose of Y90 that was delivered in that case. This is the publication again. As you can see here, this is the dose that was given, a median dose of 521 using the single compartment measurements, dosimetry. For radiation segmentectomy, again, in that article, there was no RILD for these patients. 5% only of the patients had small bilomas, which were asymptomatic, and only 1% had biliary strictures from this high dose of Y90. Now, this is a case, an example of a case. You can see here there's a tumor in segment 7, and it washes out on venous phase, so that's an HCC. This is the celiac angiogram, and you can see here's the tumor. It starts to appear. This is a microcatheter subselection very close to the tumor. And this is even more subselection, and you can see this is the segment that probably will be wiped off completely and will exhibit complete necrosis after the delivery of the Y90. And this is the cone beam CT again showing this triangular segment in which we will deliver the Y90. Here is the delivery of the Y90. The dose that was given was 520 milligrams. Again, very, very high dose, different than what the companies actually advise you to give. This is very high. And this is the follow-up. After 1 month, you can see there's complete necrosis here, complete response by M-RECIST, and that's the coronal image. And after 3 months, you can see that this area is going to start to shrink and become smaller, and this is where the term segmentectomy came from, is that this area, as if it's now removed surgically from the liver. This is a study by Vouch. They tried to correlate this high dose of Y90 technique or radiation segmentectomy with pathologic correlation. And they studied 102 patients with a solitary HCC, less than 5 centimeters. They gave a very high dose, 240 grays, or average dose. And they found out that 90 to 100% tumor necrosis on all these patients that had an explant after this Y90 treatment. They also found out that if you compare the dose of 190 or you take 190 as your threshold, the patients who were given less than 190 grays actually did not have complete pathologic necrosis. Only 3 of them did have that, compared to those who had more than 190 did exhibit much more evidence of complete pathologic necrosis. Almost like 67% of those patients had complete pathologic necrosis, and that was statistically significant between these two groups. So indications and contraindications, again, these are patients who are in the very early stage or early stage type A or 0 or A in the BCLC, and these patients usually are going to, based on the BCLC algorithm, will either get ablation, resection, or transplant. If they have a contraindication for this, if they are poor surgical candidates, or they are poor candidates of thermal ablation because of the location of the tumor or such, then they are eligible for this radiation segmentectomy treatment. It is also used for downstaging and also for bridging these patients to transplant. Technique is very easy, and like I said, it's like similar to for here in Egypt, doing a TACE, you just go as close as possible to the tumor, but instead of injecting the TACE material, you inject the Y90 at, again, very high dose. The problem also appears just like in TACE, is that we have watershed areas just like we have in the brain. And this is why sometimes when you do it, you see the tumor very well, you do the treatment, but then on the follow-up, you find the residual tumor that has not been treated, or residual part of the tumor that has not been treated. So recommendation is always to do a lobar cone beam CT, which is a CT that is done on the angio machine. And then when you get closer to the tumor, is to do another target artery cone beam CT in order to discover whether this patient has a watershed tumor or a tumor in the watershed areas. These are the most common watershed areas in the liver between segments 6 and 1, 8, 4A, 4A and 2, 2 and 3. We'll see some examples here. This is a case where we have a tumor that is between segment 1 and 6, between segment 1 and 6, and this is the venous phase. This is the selection of segment 1, that's the caudate, and you can see there's part of the tumor is coming up here, and then this is the segment 6 angiogram. This is the tumor, and this is the cone beam CT, so you can see it's actually appearing in both arteries, so you have to split your dose between these two, and you have to treat both of them. This is the treatment or the CT after treatment, the follow-up, and then after 42 months, that completely disappeared. Here's another example of a case here. This is between segment 4A and 2. There's the angiogram showing this one. And here is one of the arteries. You can see there's half of the tumor only is appearing. The other half is not there. And when you do the segment 4A, this is the angiogram showing, again, that's the hypervascularity of the tumor. And cone beam CT shows the other half. And you can use fusion softwares that are available now to see the two cone beam CTs superimposed over each other with color coding of each one between blue and red. And now you are sure that all this tumor is covered by these two arteries, and then you can give the treatment. Cone beam CT is also very important for accurate dosimetry. And this is an example of a case here in segment segment 8. And you can see here we came very close to the tumor, which is right here. And This is where we do the cone beam CT, and we can accurately calculate the volume, which is very, very important for calculating also the dose. We don't calculate, of course, the volume for the tumor only, but for the volume, of the whole segment that will be involved in the treatment, which is appearing orange in this case. This is after treatment. You can see the radioactive material in the tumor. It's a targeted therapy that goes only to that tumor. We usually, for dosimetry, which is very important topic in Y90 as always, we usually, for radiation segmentectomy sake only, we use the MERD model, which is a single compartment model. We assume that the tumor and the surrounding part of the liver that will be treated, they all have the same vascularity, and that the distribution of the Y90 material will be equal in all that area. And there's a lot of, calculators now to make it easy on you, like the DAVR or the Cancer Y90. These are all present on your cell phone these days. You can just put in the dose that you desire, the lung shunt, and the volume of the treatment area, which we, as I said, we get that from cone beam CT. There's a new paper here, not a new paper, but this is the paper that I consider as a landmark. It looked at groups of patients, that had Y90 followed by transplant, and they looked at the explants to see which patients would have complete pathologic necrosis, and found out that a dose of 400 grays is necessary in order to obtain complete pathologic necrosis in all these patients. So this is what we actually use. We always use a dose more than 400. The outcomes, this is a retrospective study comparing TACE followed by microwave versus radiation segmentectomy for solitary HCC that are up to 3 centimeters. They did 40 patients in each one using propensity score matching, and they found really no difference in terms of complete response between the two groups, whether you do with or without propensity score matching. And they also didn't find any difference in terms of progression-free survival between the two groups, TACE microwave versus radiation segmentectomy. And you can see the p-value here is insignificant. This is another study here. Sorry, this is another study, the Legacy study. It's a landmark study also for this, and it's very important. It shows that, again, radiation segmentectomy was really superior. It showed that the objective response rate was 88%. The duration of response, and most of it was complete response or partial response. The majority was almost 84% complete response. Duration of response was also important in that study. It was 15 months mean, and there was almost 76% of the patients did not have any recurrent tumor at 6 months. Again, great results here. Again, the progression-free at 24 months was 100%, and the median progression-free survival was 57, very close to the results that you get with ablation and even with transplant. The overall survival was 83% if therapy was done for as a primary therapy, if the treatment was done as primary therapy, or for all patients it was around 86%. This is a similar study, by Mount Sinai group. I'm going to skip that for the interest of time, and I'm going to skip that to the conclusion. Because of all these results, the BCLC algorithm was modified in such a way that radioembolization is now part of that treatment algorithm. So radiation segmentectomy is a well-tolerated intraarterial therapy for HCC that is less than 8 centimeters. Radiation segmentectomy is a definite therapy, could be a definite therapy, or could be a new adjuvant therapy before resection or transplantation. Again, very important is to do a treatment dose of more than 400 grays. It has very comparable outcomes to curative treatments such as resection, transplantation, and ablation. And with that, I'm going to conclude. And if I would say the take-home point here is that the dose really matters. So dosimetry is very, very important. It matters a lot. Thank you so much. Sorry about that. It's my pleasure.